Yeah, I think there is a clear rationale to analyze also ramucirumab in the first line. In the first line, as we mentioned, bevacizumab is approved in combination with chemotherapy, but only in those patients with non-squamous histology. There is a abstract presented analyzing the combination of carboplatin paclitaxel plus ramucirumab in first line. This is a phase 2 trial including 40 patients with non-small cell lung cancer, but an impressive 55% response rate and PFS longer than 5 months was reported in this phase 2 trial. So yes, I think there is a clear rationale to analyze in first line. We have a drug that is approved in non-squamous histology, but we don't have any antiangiogenic drug approved in lung cancer in patients, for example, with a squamous cell carcinoma histology.
Based on the results we saw in the second line treatment with ramucirumab about the safety with an acceptable safety profile, one may expect that this is also true in first line setting, and this is also seen in the trial combining carbo-paclitaxel with ramucirumab trial, that the safety profile was quite what we expected. So we saw again some hypertension and the thromboembolic events, but it was manageable and safe.
I actually think in the front line the use of ramucirumab will most likely be in combination with immune therapies. I've been intrigued by the data we just recently presented at the ESMO meeting on behalf of a large team of investigators. We took ramucirumab and we put it with pembrolizumab, we call it the RAMBRO trial. And that trial really, again, only being a phase 1, it's hard to make too much of it, but it showed that the combination could be used together safely. And it also showed that in lung cancer, we had 30% of patients responding. Now, you don't know if they'd respond with pembrolizumab anyhow, probably not to the VEGFR2, to the ramucirumab, but many of the patients that responded were PD-L1 negative. So I think there's something interesting there. And we're actually at Yale now seeking to do studies to look at the tumor microenvironment with biopsies pre and post to see what's happening with the tumor and the microenvironment and to vessels and to T cells and so forth.
With regard to the other VEGF inhibitors, so there are now the tyrosine kinase inhibitors, and we have now the large second-line study on nintedanib, comparing nintedanib docetaxel to docetaxel alone, and this study showed efficacy of the drug in the non-squamous population. And besides that, there are a lot of other VEGF tyrosine kinase inhibitors in development, and we have to see what comes up. I mean, we have to keep in mind that there have been a lot of patients treated already in the years before, and all these trials were negative. Not meaning that the drugs are not effective, but I think we have really to select in which patients we can have to do these trials to optimize the efficacy of this treatment. Yeah, for me, one of the remarkable things is that I thought we knew already where this was heading to with the VEGF, and what we see now with all these new data coming up is that we see some signs, we see some effects of these kind of drugs which we didn't knew before, and I think it's really important that we look at these mechanisms and we try to optimize that so to get the maximal activity of these drugs. And not use them as a large blockbusters in large populations, but really select for novel combinations based on scientific knowledge.
I guess it would be nice to see more studies of the VEGFR2 or the ramucirumab in the front line with different chemo combinations. I'd also like, based on some of the preliminary data that our group with others presented at ESMO, looking at pembrolizumab, the PD-1 inhibitor, plus ramucirumab phase 1, I'd love to see trials in the PD-L1 high group as defined by the 22C3 antibody of pembrolizumab, ramucirumab, and I would hypothesize that combination might be better than pembrolizumab alone, and also look at the angiogenesis inhibitor plus pembrolizumab maybe in the lower group. There it would have to be compared to chemotherapy, which is still the standard of care. But I think there's a lot of opportunity to use these agents selectively, because if you think you want to upset the tumor microenvironment so that there are fewer T regulatory cells to allow tumors to be more affected by immune checkpoint inhibitors, ramucirumab and other VEGF agents might have a role there.
So we are here to discuss antiangiogenesis. So as we mentioned, angiogenesis is an important hallmark of cancer. We have now a number of drugs inhibiting this process, and this is relevant for the patients. We are at ESMO, and during this ESMO meeting, again, very exciting studies analyzing immunotherapy, anti-PD-1 strategies, and anti-PD-L1 strategies will be presented here. So we are discussing also non-small cell lung cancer. We have improvements in this disease, but we need more strategies to really treat these patients with cancer. We have the combination of antiangiogenic agents plus immunotherapy, and we do believe that the possibilities for our patients are increasing, and we will have more results in the next meetings.